So the title of my talk is Diagnosis and Management of Alzheimer's Disease and Other Dementias, and I have no financial disclosures. We will discuss diagnostic criteria for MCI and dementia and the diagnostic criteria for Alzheimer's disease, and for many of you, this will be a review. I will also discuss the clinical features suggesting a non-Alzheimer's dementia, and we'll do this with a case-based approach. Just to make sure we are all on the same page, these are the DSM-5 criteria for major neurocognitive disorders, which is a term that's used often interchangeably with dementia. There should be evidence of significant cognitive decline from a previous level of performance in one or more cognitive domains. And these are the cognitive domains that we test in our memory assessment clinics: learning and memory, language, executive function, complex attention, perceptual and motor function, and social cognition. The cognitive deficits interfere with independence in everyday activities, but should not occur exclusively during delirium or in the context of another mental disorder. There are mild and major neurocognitive disorders, or the other term would be MCI and dementia. Mild neurocognitive disorders result in modest cognitive decline from a previous higher level of performance in one or more cognitive domains. They do not interfere with independence in everyday activity, although greater effort and compensatory strategies are needed. On testing, the results fall 1 or 2 standard deviations below the norm. As we just saw, major neurocognitive disorders result in significant cognitive decline in one or more cognitive domains. They do interfere with independence in everyday activities, and these individuals require assistance in their IADLs and later on also in their ADLs. Test results typically fall 2 or more standard deviations below norms. There are many different causes of neurocognitive disorders. The neurodegenerative causes include Alzheimer's disease, frontotemporal dementia, and dementia with Lewy bodies. We also see vascular cognitive impairment and often mixed dementia. As much as we would like our patients to have just one diagnosis, we just have to be realistic that patients often have dual pathology. The older they are, the more likely this is going to occur. So we can see Alzheimer's disease with vascular cognitive impairment or Alzheimer's disease with dementia with Lewy bodies or any other combinations. There are many other neurocognitive disorders, and we will not be able to cover them all in detail today. I just wanted to mention a few. Traumatic brain injuries can result in cognitive disorders, so we may see that in our veterans, for example. And then chronic traumatic encephalopathy has been diagnosed in patients with who have had concussive injuries or football players. Movement disorders can result in cognitive disorders, normal pressure hydrocephalus, substance abuse, and a variety of infections, among them HIV infections, neurosyphilis, or prion disease. And for the first time this year, I've included post-COVID-19 neurocognitive disorders. That's a condition for which we don't even have a diagnosis or a proper term yet. We don't have diagnostic criteria yet, but we now see increasingly that patients who have survived COVID-19 struggle and often have cognitive difficulties, for which we are now seeing them in our clinics. We always look for the reversible causes of neurocognitive disorders, and depression leads to the classic pseudo-dementia. If depression is treated and the cognitive decline reverses, then we call it pseudo-dementia. We see metabolic and endocrine disorders, vitamin deficiencies, severe anemia, medication effects, very important in our elderly population. Anticholinergic medications, pain medications, or sedatives are often the culprits. And then one of the reversible causes we should keep in mind is autoimmune encephalitis, and we'll talk a little bit more about it later. When it comes to testing, we want to have at least some routine testing, make sure we're not missing anything, like a metabolic panel, complete blood count. We want to look at their vitamin B12 level, their thyroid function, And we want to do at least some type of structural imaging, like a CT scan or an MRI, and in some patients, syphilis serology might be indicated. On the right side of this slide, I've included additional tests that would be used in the appropriate clinical setting, but it's certainly not something we would do routinely. So let's start by looking at a patient's case. This is a 78-year-old woman who was referred to a memory clinic for forgetfulness. She was accompanied by her daughter, reported that her mother had started to become forgetful about 3 years ago. She would sometimes repeat stories or forget events or conversations, but she was functioning pretty well on her own. 6 months ago, though, it became apparent that she was not functioning very well anymore. The family came to visit for Thanksgiving, and the household was in disarray. She had not taken her medications, the bills were piling up, she had forgotten appointments, and when the family tried to enlist some outside help, she resisted both verbally and physically. She had a sister, an older sister, with advanced Alzheimer's disease who was already institutionalized, and her exam was pretty normal, and she had normal screening labs. She underwent neuropsychological testing, and as you can see, her mini-mental was 20 out of 30, 6 out of 10 of the clock draw, and then she was able to name only 7 animals in 1 minute. Her neurocognitive profile shows that naming was mildly impaired, but construction and memory were moderately impaired, and she was kind of holding her own in the other cognitive domains. She had a brain MRI, which does show atrophy of the temporal lobes on both sides, as well as mild atrophy of the hippocampus, more on the left than on the right. So this is a patient where we feel pretty confident that we can make a diagnosis of a major neurocognitive disorder or dementia due to Alzheimer's disease. And we can do that almost entirely on clinical grounds. She's older than 65. There's already a family history of Alzheimer's disease. She's had a gradual function decline. She has early and prominent decline in her memory, and the neuropsychological test profile is consistent with that as well. She does have atrophy of the temporal lobes and of the hippocampus on her imaging, and no significant vascular disease on her imaging. That is very much in line with the diagnostic criteria from the National Institute on Aging and Alzheimer's Association for probable Alzheimer's disease dementia. So criteria for dementia are met with an insidious onset over months to years with clear-cut worsening in 2 cognitive domains. And these patients either have an amnestic or non-amnestic presentation. In addition to clinical features, we also look at biomarkers. And a detailed discussion of these biomarkers is beyond the scope of this talk today, but I wanted to give you a brief overview of the Atn framework, the Atn biomarkers. A stands for amyloid accumulation, T stands for fibrillary tau, and N stands for neurodegeneration. Using these biomarkers helps with diagnostic accuracy in symptomatic patients. It may predict which patients with MCI are going to have further cognitive decline, and it's certainly helpful in the research setting in the pre-symptomatic stages. So the marker of amyloid accumulation is decreased amyloid in the spinal fluid because the amyloid has accumulated in the brain tissue, and we can see that on an amyloid PET scan. A marker of fibrillary tau would be an elevated phosphorylated tau and total tau in the spinal fluid with PET imaging showing tau accumulation as well. And then we also have markers of neuronal injury or neurodegeneration. Those are tests that we use more often in a clinical setting already. So for example, the metabolic PET scan of the FDG PET scan, which classically in Alzheimer's disease shows temporoparietal hypermetabolism, as on this slide here. Another marker of neuronal injury and neurodegeneration is the structural imaging. So we can see cortical atrophy that is usually progressive affecting the hippocampus, but also other areas of the cortex. And this here is a classic example of somebody who has medial temporal lobe atrophy with fairly profound atrophy of the hippocampus. When it comes to treatment, we don't have much to show for yet, especially when it comes to pharmacological treatment, although Dr. Carlson just mentioned that we are closer to disease-modifying treatment. At this time, we're limited to the cholinesterase inhibitors, which are all FDA approved for the treatment of mild to moderate Alzheimer's disease, and in the case of donepezil, for the treatment of severe Alzheimer's disease. We also have memantine, which is an NMDA receptor antagonist. It is FDA approved for moderate to severe Alzheimer's disease. More important than the pharmacological treatment is the symptom management. We do need to support the patients and their caregivers, and the focus should be on non-pharmacological treatment, especially if it comes to behavioral management. We'll hear more in the next talk about pharmacological symptom management of behavioral problems. Just as a preview, we often use the citalopram for depression and agitation and trazodone for sleep. But most of all, we want to avoid medications that can make things worse, like neuroleptics, benzodiazepines, and antihistamines. Some patients are younger than 65 when they develop dementia, and the differential diagnosis is a little bit broader, especially in the younger age group between the ages of 17 and 45. Frontotemporal dementia is the most common cause, followed by Huntington's disease and multiple sclerosis. When we look at patients between the ages of 30 and 65, Alzheimer's disease does move to the top. So Alzheimer's disease is the most common cause of dementia, even in those young patients. Although vascular cognitive impairment, frontotemporal dementia, and other dementias should be considered as well. Early onset Alzheimer's disease is diagnosed if the symptoms start before the age of 65. This is 5 to 6% of all Alzheimer's disease. There's often a strong genetic predisposition. 10% of early onset Alzheimer's disease patients have an autosomal dominant familial pattern with mutations of the presenilin 1, presenilin 2, and amyloid precursor protein mutations. These patients often have a much more aggressive disease course with a more rapid progression, unfortunately. And clinically, they can also look different than the late onset Alzheimer's disease patients. There is a higher percentage of non-amnestic phenotypes, and this unfortunately often leads to misdiagnosis or delayed diagnosis. The logopenic variant of primary progressive aphasia is the most common non-amnestic phenotype. We can also see posterior cortical atrophy, which leads to visual impairment, behavioral, and a dysexecutive variant, which can lead to a frontotemporal dementia type of picture, and parietal symptoms with acalculia. Imaging sometimes is also different in early onset Alzheimer's disease than in late onset Alzheimer's disease, with less radiographic involvement of the hippocampus and the temporal lobes, and greater radiographic involvement of the parietal lobes and temporoparietal junction. These patients also have greater psychosocial needs. And I'm just going to move a little bit because my lights went out in the office because I was sitting so still. So forgive me if I'm moving so you can see me a little bit better. Okay, so the lights are back on. Most of the time you feel pretty confident when we make a diagnosis of Alzheimer's disease, but sometimes our patients present with symptoms that may point towards a non-Alzheimer's dementia. And what are those symptoms? I've summarized them in a mnemonic, when to be bashful about Alzheimer's disease, and just to be sure, all these symptoms and features can be present in Alzheimer's disease, and they can develop at some time during the disease course, but if they're present early on or present very prominently, we should at least consider a different diagnosis. B stands for behavioral changes, so prominent and early behavioral changes should make you think about frontotemporal dementia. Age of onset before the age of 65 can still be seen in Alzheimer's disease, but again, the differential diagnosis is more broad, as I showed you a little bit earlier. If seizures occur early on, especially right in the beginning of the diagnosis, we should think about something structurally, but also about autoimmune encephalitis. Speech impairment in the early stages would point towards a possible diagnosis of primary progressive aphasia. Hallucinations can occur in dementia with Lewy bodies, and then F stands for football, so patients who have had repeated concussive or subconcussive injuries may present with cognitive difficulties due to CTE. Falls early on should make us think about movement disorders, and so do the abnormal neurological exam and other signs of a movement disorder. And the disease course is also important to note. If there has been a stepwise progression of the disease course, we should think about vascular cognitive impairment, or if there's a rapidly progressive disease course, we should think about a variety of rapidly progressive dementias, and we'll come back to that topic in a little bit. So with that in mind, let's look at another case. This is a 53-year-old gentleman who came to our clinic with a 2-year history of behavioral changes. He was brought in by his wife. He didn't think at all that there was anything amiss. His wife reported a decline in his social skills, and because they both worked in the same office, she also knew that things were not going well at work. He had no interest in interacting with his coworkers or with clients. He would not answer the phone when it rang, and he also was less emotional with his wife and their 9-year-old son. He used to be the computer whiz in their office, but he now needed help with some of the basics. He no longer had any interest in his previous hobbies, but he was obsessed with running the washing machine. There had been a decline in his personal hygiene, and he had not shown any change in his food preferences. There was no disinhibition in his behavior, and at least on a casual conversation, there were no apparent speech or memory problems. His family history was interesting. His mother was diagnosed with dementia at the age of 62. She died in her 70s, and there was no formal diagnosis made, but she definitely had early onset dementia. His older sister was diagnosed with frontotemporal dementia with motor neuron disease, which is another term for ALS. She died at the age of 57, and this diagnosis was autopsy confirmed. Another sister was alive at the age of 62. She was diagnosed with a mental illness, and she had a hoarding type of behavior. And although this is certainly not diagnostic, at least suspicious for a similar condition. His physical exam and the neurological exam was normal, and he had normal screening labs. He underwent neuropsychological testing in our lab, and on the R bands, the scores for visual spatial function, construction, and delayed memory were average. Low average on immediate memory and attention, and language was mildly impaired. For that reason, he was taken to our neuropsychology lab, where he had additional testing of his language, clearly impaired comprehension and confrontational naming, and executive function was tested as well and was abnormal, with impaired novel problem-solving skills, perseverative responses, and he was very impulsive on test taking. He also had a brain MRI, which was interpreted as normal, but I hope that you agree with me that for somebody his age, there was definitely more cortical atrophy than one would normally see, involvement of the frontal lobe predominantly. What I also want to show you is that there was not really much atrophy of the hippocampus or the medial temporal lobe here. He underwent further testing, and he had a metabolic PET scan of the brain, which was abnormal. So everything that's green on that slide is abnormal. And you can see here that there's hypermetabolism of the frontal lobe and of the anterior temporal lobe. Based on this information, we've diagnosed him with behavioral variant frontotemporal dementia, and these are the diagnostic criteria. Clinically, patients develop either with present with either a disinhibited phenotype or more with an apathetic phenotype. Patients who are disinhibited showed socially inappropriate behaviors, loss of manners and decorum. They can be impulsive or careless. Other patients like ours are showing more apathy or inertia, but often we see a loss of sympathy or empathy and perseverative or stereotyped behaviors, like our patient who had to run the washing machine at all times. He did not show hyperorality and diarrhea changes yet in the early stages. On neuropsychological testing, we often see deficits on executive function and on language testing, like in our patient, while memory and visual spatial functions are relatively preserved, especially early on. Imaging will show atrophy of the frontal lobe or the anterior temporal lobes, and the same areas will also be affected on functional imaging when we do a PET scan or a SPECT scan. The behavioral variant frontotemporal dementia is only one of the frontotemporal dementias and related disorders. The other one that we're all aware of is the primary progressive aphasia with its three variants, the non-fluent, semantic, and logopenic variant. Just wanted to point out that the logopenic variant of frontotemporal dementia is believed to be related, or is known to be related most of the time, to Alzheimer's disease rather than FTD, but is grouped here among the primary progressive aphasias. There are also two movement disorders, cortical basal syndrome and progressive supranuclear palsy. They are considered FTD-related disorders. And then we have frontotemporal dementia with motor neuron disease, which is also an FTD-related disorder. To come back to our patient, 1 year later, he required 24-hour supervision. He was now nearly nonverbal, continued to have very compulsive behaviors, and had developed restricted food preferences. More concerning, though, was that he had developed swallowing problems and significant weight loss. When I examined him, he had atrophy of the tongue and of the extremity muscles, and he had developed fasciculations. The presence of a motor neuron disease was confirmed on the EMG, so he now also had ALS. He had a very rapid decline over the course of several months and then passed away within 3 years of the diagnosis. So in addition to the behavioral variant frontotemporal dementia, he's also now been diagnosed with motor neuron disease, or ALS. And this is something that may occur together, and the behavioral changes may precede, follow, or coincide with the symptoms of motor neuron disease. It often runs in families, like in this gentleman's case, and there's one particular gene mutation that's most common, the mutation of the C9 open reading frame 72 gene, which has been studied quite a bit in recent years. As you would expect, these patients have fairly short survivals of only 2 or 3 years. How do we treat frontotemporal dementia? We don't really have a whole lot to treat, but the symptomatic and supportive treatment of the patient and their family is very important. And because they can develop additional movement disorders or motor neuron disease, they should at least be examined once a year. We will hear more about the treatment of their behavior, but SSRIs and trazodone are often used. Cholinesterase inhibitors are ineffective and can even make things worse, so we don't use them in these situations. And in a situation like this one, genetic counseling, of course, would be very important as well. As I mentioned earlier, primary progressive aphasias are the other group of frontotemporal dementias with the 3 subgroups. We will not have time on this talk to cover them in detail, but I have included a slide for your reference that tells you what to look for to tell you whether somebody has the semantic, the non-fluent, or the logopenic variant. You may need a good neuropsychologist or a speech pathologist to help you out with that, but there's some pointers here in that slide that show you which language function is impaired and which language function is less impaired. That may help you make at least a preliminary diagnosis. Let's move on to another patient. This is a 67-year-old, recently retired high school science teacher who was referred to us for a 1-year history of increasing forgetfulness. His most prominent difficulties, though, were with numbers and calculations. He had difficulties telling time, although his family said that he had absolutely no difficulties with driving. They also reported that he had fluctuations in his functional status. There were days when he looked much better, and then other days where he was much more impaired. There were no behavioral changes, but the patient reported brief and non-threatening visual hallucinations. He also had a very active sleep. He would shout or kick or punch in his sleep, and his wife had actually moved to a different bedroom to stay safe. His general exam was normal, but the neurological exam was abnormal. He had rigidity in both arms and bradykinesia, meaning that he had very slow and stiff movements. His screening labs were normal, and when he was seen 1 year later, there had been further functional decline. In the meantime, he had also had several syncopal spells, and he was still quite rigid and slow. I'm going to show you his neuropsychological test results superimposed on each other. They were done within with 1 year difference and fairly stable over time. The most prominent deficits were in construction and calculation, while memory was only mildly impaired. And I just have to show you, oops. If you can still hear me, I just wanted to let you know that my slides just froze. Here we go.
There we go. Yeah, we can hear you still, Suzanne. Yep.
Okay, perfect. And can you see my slides as well?
Yes, we see the clock draw currently.
Okay, perfect. That's what I wanted to show you. This is his clock draw. So just a couple of years after he retired as a science teacher, and I thought that this clock was quite remarkable. He also had imaging, which was not overly revealing. Some atrophy here, some cortical atrophy, and most important for us to note here is that he had no atrophy of the temporal lobe, the medial temporal lobe, or the hippocampus. So this is a gentleman who can be diagnosed with dementia with Lewy bodies, and it looks like this is a fairly complicated diagnosis to make because there are all those clinical features and biomarkers, and I'm just going to walk you through mostly the clinical features. So of course, the essential feature has to be dementia, although in the early stages, we may see mild cognitive impairment. The cognitive decline is progressive, and we see the most prominent deficits on attention, executive function, and visual spatial abilities, while memory may be preserved for a bit longer. Core features include fluctuating cognition. So these patients have very pronounced variation in attention and alertness. They may have good days and bad days, and we see recurrent visual hallucinations, which are often well formed in detail and may occur early on. Another feature of dementia with Lewy bodies that's important to note is the presence of a REM sleep behavior disorder, where patients act out their dreams. This may even precede the disease onset by years, sometimes even by decades. And then, of course, they should have one or more spontaneous cardinal features of Parkinsonism. We see more of an axial tendency. This means they are more stiff and slow, and tremors may not be present early on. There's a whole host of supportive clinical features, and I've highlighted the ones that are most important. The sensitivity to antipsychotic or antidopaminergic agents is important to note, because if these patients are given these medications, they can develop even life-threatening complications, specifically severe autonomic dysfunction. They do have autonomic dysfunction at baseline. Behaviorally, patients often have more apathy and anxiety and depression than other patients with dementia. We're not going to walk through all the biomarkers, but one biomarker that I wanted to point out is the presence of a REM sleep behavior disorder on their sleep study. And a supportive biomarker would be relative preservation of the medial temporal lobe structures on imaging, as we saw in this patient as well. And on functional imaging, we may see reduced occipital lobe activity, as opposed to Alzheimer's disease, where we see the temporal and parietal lobe involved. The neuropsychological profile can also tell us some differences compared to Alzheimer's disease. And I've now grouped dementia with Lewy bodies together with Parkinson's disease dementia because neuropsychologically, this may look very similar. So memory impairment more prominent in Alzheimer's disease, visual spatial impairment more prominent in dementia with Lewy bodies, and Parkinson's disease dementia, hallucinations, depression, and apathy more prominent in dementia with Lewy bodies than in Alzheimer's disease. And how would you know whether your patient has dementia with Lewy bodies or Parkinson's disease dementia? This is entirely based on the clinical clinical course and the time course. So if the cognitive impairment develops before or within 1 year of the Parkinsonian motor symptoms, we diagnose dementia with Lewy bodies. But if the cognitive impairment develops in well-established Parkinson's disease after more than 1 year, we're more likely dealing with Parkinson's disease dementia. Treatment focuses, first of all, on the avoidance of anticholinergic and neuroleptic drugs, as I mentioned earlier, because they're very sensitive to those drugs. Sometimes Parkinson's medications can be helpful, so carbidopa, levodopa is often tried. And the response to cholinesterase inhibitors may be more robust than in Alzheimer's disease, so it's always worth trying this. And then again, SSRIs for depression and anxiety. Sometimes the psychotic symptoms need to be treated, and we'll hear more about this later. And clonazepam or melatonin can be used for the REM sleep behavior disorder. I have another vignette that we can go through really quickly. This is a 72-year-old gentleman who was referred to my general neurology clinic for cognitive decline. His wife said that the onset of the forgetfulness was rather sudden, about 10 months prior. She also noticed some personality changes. He had been a rather ornery guy, and she thought that he was much more pleasant lately, so she was not too concerned about this. But she did notice that he had difficulties remembering names, couldn't balance the checkbook anymore, and he would forget appointments. About 5 months ago, he developed right-sided weakness, but because it got better within a few hours, they did not seek medical attention. And that has always been his approach to his medical care. He was very proud that he had always been healthy and had not seen a doctor in 8 years. He had a 50-pack history of smoking and a family history of stroke and several male relatives. When he was seen by his primary and then by us, he wasn't that healthy after all. He had hypertension. He did not do too well on the MOCA and had deficits on delayed memory, attention, and executive function. He did have an abnormal neurological exam with mild right-sided weakness and difficulties with a tandem gait, and he did have an ugly set of labs with elevated glucose, cholesterol, and creatinine. We almost don't need to see the MRI because we already think we know what's going on. So everything you need to know is in this one slide of his MRI. He does have a cortical stroke here in the left frontal lobe. He does have a fairly large subcortical stroke here with widespread white matter disease that's confluent. There are even some lacunar strokes embedded here, and then he also had an older cerebellar stroke. This is somebody who can be diagnosed with vascular cognitive impairment, and these are the diagnostic criteria based on the criteria from several professional societies. Essentially, we see cognitive impairment that is caused by or associated with vascular factors due to cerebrovascular disease or cardiovascular disease. Clinically, these patients often have a stepwise progression like our patient. It is common, but it's not required for the diagnosis. Neuropsychologically, these patients are have more apathy and depression and more of a subcortical type of dementia with executive dysfunction and diminished processing speed. If there are cortical strokes, we will see additional deficits in cortical domains and, of course, deficits in the neurological examination as well. There are different radiographic patterns in vascular cognitive impairment, which correlate with a clinical phenotype. So this is the classic post-stroke dementia with predominant cortical vascular disease due to large vessel ischemic stroke and hemorrhagic strokes. And then we can see more of a subcortical pattern where patients have multiple lacunar infarcts or ischemic white matter disease that's prominent. Other features include dilated perivascular spaces. Another pattern that we often don't remember is the hyperperfusion pattern. These are patients who may have survived cardiac arrest and had an anoxic brain injury. They developed cognitive difficulties due to hyperperfusion, and on imaging we may see hippocampal sclerosis or laminar cortical necrosis as a consequence. Treatment, of course, focuses on the prevention of further strokes. We also need to know that vascular disease increases the risk of Alzheimer's disease, and both conditions may coexist, and that's why it is reasonable to try a cholinesterase inhibitors in these patients as well. I do have one quick vignette that we will go through. This is a 62-year-old gentleman who was seen by us on the neurology consult service. He had been admitted with severe ataxia. He couldn't walk safely anymore, and he had some behavioral changes. His history included severe insomnia for the past year, which was very uncharacteristic for him. And then 3 months ago, he developed balance problems, which worsened now to the point that he could not walk anymore. His family also reported personality changes. He had become more irritable, and they noticed that he could not take care of himself anymore. In the last month, they had to help him out at home. When we examined him, he had 16 out of 30 on the mini-mental, 0 out of 3 recall, clock draw was 4, and animal fluency was just 1. On a neurological examination, he had severe cerebellar dysfunction, and he had additional cortical deficits with aphasia, apraxia, and visual spatial dysfunction. So this is somebody who can be diagnosed with rapidly progressive dementia. We call it rapidly progressive dementia if there is progression from normal cognition to dementia in less than 2 years, but most progress over weeks to months, like in our gentleman. Another definition is a decline in the mini-mental of more than 3 points in 6 months. Many of those patients with rapidly progressive dementia will not have a treatable cause, but some causes are treatable, and that's why it's very important to look at these patients very carefully. So the non-treatable cause, of course, is the prion disease or CJD, the Creutzfeldt-Jakob disease, but the treatable cause is autoimmune or paraneoplastic encephalitis, so we always want to think about that diagnosis. Other conditions that can cause rapidly progressive dementia include infections or even neurodegenerative disorders, including Alzheimer's disease. To come back to our patient, he had a brain MRI at the time of his admission, and initially this was interpreted as normal, but when we took a look at it, we thought that there was already a hint of something to come. You can see kind of a white ribbon-like signal changes along the cortex. And when the MRI was repeated 6 days later, it was much more prominent. You can now see the cortical signal changes, and this is called cortical ribboning. This is very strongly suggestive of Creutzfeldt-Jakob disease or CJD, and this was also then confirmed on his spinal fluid examination. We do know about the protein 1433. We have known about this for years, that this can often be positive in patients with CJD, but it's not a diagnostic test. In this patient, he also had an elevated tau protein and very elevated tau protein in his spinal fluid, and then a positive Quicken test, which is actually a test that discovers even small amounts of prion protein in his spinal fluid. And based on the combination of these findings, he was given a probability of having prion disease of greater than 98%. Unfortunately, he had a very rapid decline. He was unable to talk. He developed cortical blindness and myoclonus. He had periods of severe agitation, and he passed away 2 weeks after the admission. So very rapid disease course, and the diagnosis was confirmed on autopsy. CJD or Creutzfeldt-Jakob disease is a rare condition, 1 in a million patients, and that would make it about 5 per year in Wisconsin. These patients present with rapidly progressive dementia, but in this case, this patient also rapidly progressive ataxia, which can sometimes be the first symptoms, and then there are often behavioral changes in myoclonus. The diagnosis can often be based on the MRI, like in our patient, he had the cortical ribboning, but other patients may have enhancement of the basal ganglia, which is another classic pattern. And then if the spinal fluid examination is helpful, we can often avoid the brain biopsy, although we do prefer to have an autopsy to make sure that we're really that we really know that this was CJD. And unfortunately, there is no treatment. There is treatment for autoimmune encephalitis, though, and even if you do not think that you would be involved in a diagnosis or treatment of autoimmune encephalitis, I wanted to give you at least some clues in the history. So again, these patients have a subacute, acute cognitive decline, less than 3 months disease course, often a viral prodrome. And in addition to the cognitive decline, these patients can have autonomic dysfunction, neuropsychiatric symptoms, and seizures. So seizures early on, together with rapid cognitive decline, should definitely point towards an autoimmune encephalitis. Others may develop new onset status epilepticus. We can see a history of autoimmunity in the patient or their family, or a history of cancer. The MRI may be completely normal, but in others we may see signal changes in the temporal lobes. There are some classic EEG patterns, and ultimately the diagnosis is made when we see autoimmune or paraneoplastic markers in the serum or the spinal fluid. Treatment may reverse or even improve the symptoms, and we use immunosuppressant agents like steroids, IVIG, or plasma exchange. And in some patients, this may actually lead to dramatic improvement in their cognitive and other symptoms. And I'm ending my talk with this slide. This is a picture of Devil's Lake State Park, which is my favorite place in Wisconsin at this time of the year.